All right. Good morning, everyone. And a beautiful sunny day again. It's like California, Pittsburgh, right? This is a special day, so welcome everyone to the Pediatric Grand Rounds. We're gathered once more honoring Dr. Zuber Buehler. We were very saddened in 2019 with his passing, and every year we celebrate his legacy with an invited speaker to share new knowledge with us. And for some of you who may not know or not remember Dr. Zuber Buehler, I'm going to go very briefly over some of his history and his contributions to the field. Dr. Zuber Buehler was a local. He did his undergraduate at Allegheny College, and then medical degree in University of Pennsylvania, internal medicine residency at Penn, and then a cardiology fellowship, an adult cardiology fellowship. You have to realize that in those days, there was not pediatric cardiology, was not much of a specialty in the University of Michigan. And then he served in the military for 2 years in the tour of duty and in the Air Force. And although his training was in adult cardiology, he clearly had a passion and calling for pediatric cardiology, especially congenital heart defects. Heart disease in children, he said in an interview on the Pittsburgh Port Gazette, is hundreds of different anomalies and hundreds of combinations. It's like putting together the pieces of a puzzle. Adult cardiology, you're dealing with blood pressure, coronary disease. That's interesting, but not nearly as interesting as congenital heart disease. So he was had no regrets about working in the field of pediatric cardiology and dealing with kids. His medical legacy was tremendous, and with a significant amount of service at Children's Hospital of Pittsburgh. You can see here some of the old pictures with hospital leadership, including Dr. Andrew Urbach, David Feingold, some of you may know. And he was chief of pediatric cardiology from 1967 to 1994, acting chair of pediatrics from 87 to 88, assistant CHP medical director 82 to 94, children's medical director for 2 years after that, vice chairman of the Department of Pediatrics from 88 to 94. He was a member of the board of Children's Hospital, a member of the executive committee, and there are many more significant contributions in terms of service to our institution. And here below is a picture in the division from some of the old leadership at the time. Dr. Bob Anderson, who would come and spend summers from the UK here with us, here with them in Pittsburgh. We can see Dr. St. Park, and on the other side, young Lee Bierman as well, who is here in the audience. And you know, Dr. Zuber Buehler trained and mentored entire generations of medical students, pediatric residents, and pediatricians, and cardiology fellows. And this is one of the pictures from a historical photograph. We see a young Zuber Buehler surrounded by many of those who really built the program here in Pittsburgh, Dr. Sam Park, and again, you can see Lee Bierman in the back here. And Cora Lennox in the center. And Cora, well, this is our heart specimen collection, is named under her name. And it's just a fantastic heart specimen, heart museum that we have, that our students, fellows and trainees, and people all over the world are able to enjoy through some webinars and other courses that we do in morphology. He was a master clinician, incredible physical diagnostician, authored a textbook, Clinical Evaluation of Congenital Heart Disease. He was a very effective leader, teacher, and he had clarity, intelligence, and brevity. And these are some of the reflections that people had over him. Dr. Netches, who is the diagnostician, free of pretension, sense of humor, infectious warmth, endeared him to students, colleagues, patients, and their families. One of the nurses who worked with him for many years would say that he reminded her of an old country doctor because he was very down to earth and very comforting talking to families and never put himself above the families and the patients he cared for. So then there's also the extensive contributions and papers that were really significant, seminal articles on congenital heart disease, from Epstein's anomaly to trilogy of Fallot, others, ventricular septal defects and cohort, etc. So many significant contributions that get referred to over and over in the literature. Then he also had an interest in hypertension and altitude. He did have a passion for the mountains and not only studied the effects of altitude on congenital heart disease, but he personally experienced. He summited Mount Whitney in the Sierra Nevada mountains, backpacked the Grand Canyon, climbed Mount Emei, Holy Mountain in China. So really, really incredible. And there he is with St. Park in a skiing event. So he established an environment of camaraderie and team spirit in pediatric cardiology that I think we all enjoy today. And it is that culture that remains in the Heart Institute. So we are extremely grateful to stand in the shoulders of giants, and especially grateful to Dr. Zuber-Buehler for the program he built. He also is a local legend here, is with his horse. You can see he has created a website with descriptions of over 900 species of wildflowers in Pennsylvania. So he loved nature and he loved the environment, through a legend in the area. Now, every year we honor Dr. Zuber-Buehler with Pediatric Grand Rounds, and this has been since 1995 with Bob Freedom. And you can see the list of honorees. And today we have the special honor to have with us Dr. Mary Mullen. She's an old friend of mine from my Boston times. She graduated from Harvard College. She is a true complete Bostonian, grew up in Boston and did all her education there, and did PhD at Harvard Medical School. She trained in med-peds and also the Pediatric Cardiology Fellowship, and she did additional cardiology training. She's a senior associate cardiology at the Boston Children's. She's an associate professor of pediatrics at Harvard Medical School. She has extensive number of publications and contributions in the field. Her passion is in the area of pulmonary hypertension, and she directs the pulmonary hypertension program at Boston Children. She's also vice chair of the PPH network and has a significant role in many research and collaboratives at national level on pulmonary hypertension. She's also an award-winning medical educator, has a big role in the School of Medicine at Harvard Medical School. So we're very happy to have you today, Mary. And she will be talking about new frontiers in pediatric pulmonary hypertension.
Terrific. Well, thank you so much to Dr. Kreutzer, to Dr. Feingold, and to all of you for this wonderful invitation to speak here. I'm truly honored to speak at this particular lecture honoring Dr. Zuber-Buehler, Dr. Zub, really such a marvelous figure and such a person to emulate, terrific clinician, gifted teacher, and it's really my pleasure to speak today in his honor. So pulmonary hypertension in children is really a unique spectrum of clinical conditions. It's a very multidisciplinary field, and it's a very exciting field. It's currently thought to be one of the areas in pediatric cardiology which is just exploding with new drugs, new translational, and really a basic science understanding. So pulmonary hypertension is associated with important genetic diagnoses and developmental processes. And there's a tremendous opportunity for us to understand this disease further and to develop new treatments. So today I'm going to speak a little bit about an update in pediatric pulmonary hypertension, particularly from the 7th World Symposium, the definition, epidemiology of the disease, how do we characterize the disease, and talk a little bit about treatment algorithms based on risk, because that's really how we decide on therapy for pediatric pulmonary hypertension. And then, because this is a pediatric Grand Rounds, there are some particular areas that speak to future opportunities, particularly in patient-centered aspects of PH management. So the definition of pulmonary hypertension in children is the same as adults, a mean PA pressure greater than 20 millimeters of mercury, defined in the cardiac catheterization laboratory. We really define pulmonary hypertension as either pre-capillary or post-capillary, and there are rare diseases of the capillary bed, such as pulmonary veno-occlusive disease or pulmonary capillary hemangiomatosis. We use a different definition in PVR based on children versus adults because systemic and pulmonary blood flow change proportionally with size, while the transpulmonary gradient does not change. And when we look at precapillary, it's really a pulmonary capillary wedge pressure less than 15, whereas postcapillary is a pulmonary capillary wedge pressure greater than 15, reflecting pulmonary venous hypertension. And one can have combined pre- and post-capillary pulmonary hypertension, which have aspects of both diseases. And that's an area of particular interest now, particularly for people who are studying pulmonary vein stenosis and left heart disease. So pulmonary hypertension is really divided into 5 categories, 5 groups, and every 4 years in the World Symposium, these are updated. And this is the most current updated classification. And some of the things that apply particularly to children are highlighted here in red. And as you can see, there's the idiopathic and heritable group in pulmonary arterial hypertension, or group 1. That also includes congenital heart disease and particularly for pediatrics, persistent pulmonary hypertension of the newborn. Group 2, associated with left heart disease, includes all systolic and diastolic heart failure, valvular heart disease, and congenital conditions such as pulmonary vein stenosis. Group 3 is pulmonary hypertension associated with lung disease, and particularly of interest is developmental lung disease, and that's a growing interest with patients with bronchopulmonary dysplasia, congenital diaphragmatic hernia, or trisomy 21. Group 4, pulmonary hypertension associated with chronic thromboembolic disease. And then group 5 is a very interesting category because it includes some of the complex congenital lesions, such as single ventricle heart disease, tetralogy of Fallot with multiple sources of pulmonary blood flow, or scimitar syndrome. And there's a typical hemodynamic profile in each World Symposium group. So group 1 actually looks very similar to group 3 in the cath lab. Group 2, as we talked about, has that elevated pulmonary capillary wedge or left atrial pressure, and then you can get combined disease. Group 4 often looks like group 1. And group 5, particularly in our single ventricle population, actually has a lower definition for some patients with a mean PA pressure greater than 20, defining the disease. So we know that pulmonary hypertension etiology is different in adults and in children. And this slide just shows the most prevalent forms of pulmonary hypertension in adults, which are left heart disease and lung disease. And the most prevalent forms of pulmonary arterial hypertension, or group 1, in adults really vary worldwide. And if you look, you can see that there are a lot of patients who have idiopathic disease, but also there are patients that have portal hypertension. And then a major cause in some parts of the world is schistosomiasis, which has to do with the life cycle of the organism. So how do we really understand how these categories and these classifications occur in children? Well, we have used a registry in North America called the Pediatric Pulmonary Hypertension Network Registry. And this was a UO1 initiative really to capture diverse forms of pulmonary hypertension. And this included 13 academic centers. It's now up to 17 centers. And we include children up to age 18 diagnosed with pulmonary hypertension by these criteria. We have over 2,200 patients enrolled in this registry, and this is a very active process. It's really helped us understand the disease in children. These are some of the sites that are involved in this initiative. And we really learned a lot about pediatric pulmonary hypertension by characterizing this group. So you can see in this pie chart that in children, pulmonary hypertension is really 50-50 group 1 and group 3. And group 1 consists predominantly of congenital heart disease, 2/3, and 1/3 of idiopathic or heritable disease. Group 3 includes primarily the developmental abnormalities of the lung, and particularly bronchopulmonary dysplasia and congenital diaphragmatic hernia. And this is really a very different grouping than is seen in our adult patients. And so our treatment strategies really have to differ for these patients, and we have to think about these patients differently. When we compared group 1 and group 3, there are actually differences. Group 3 patients are younger. There are sex and racial differences, and there are treatment differences. Group 3 is more likely to be treated, of course, with respiratory treatment, and in our registry is less likely to be on PH meds than group 1 disease. There are differences in functional class, particularly at enrollment, and importantly, there are differences in outcome by this group. And so this tells us that this is not a one-fits-all of pulmonary hypertension in children. We really have to define the disease, classify our patients, and develop treatment strategies for each one of these groups. Now, in children, pulmonary hypertension is a heterogeneous disease, and there is more than one contributing etiology. And this is really true to contribution of abnormalities of lung growth and development. We know that pulmonary hypertension in some cases can develop in utero and can be superimposed postnatally on essential periods of lung development. And this can really lead to unique airway growth or pulmonary vascular disorders. And there are particular disorders that are unique to childhood. We have the axis of time, developmental lung disease, genetic associations, syndromic pulmonary hypertension, as well as nutritional deficiencies. So the axis of time is really important in pediatrics because the disease difference, depending on whether this is fetal vascular development, neonatal presentation, pediatric disease, or later on adult disease. And we know that developmental causes of pulmonary hypertension are very unique in children. And this includes things like bronchopulmonary dysplasia and congenital diaphragmatic hernia, as well as trisomy 21, but also unique disorders such as TBX4 syndrome, ACD or alveolar capillary dysplasia at birth, and other very rare but important causes of neonatal lung disease. And in pediatrics, 42% of pulmonary hypertension is attributed to genetic disorders. And that is substantially more than what we've seen by sequencing in adults, where less than 13% are attributed to known genetic disorders. And this is a summary of our pediatric genetic syndromes. And interestingly, they are really defined syndromes. So BMPR2, TBX4, ACVRL1, and SOX17 are the predominant genetic associations. But each one of these are different, particularly TBX4, which has a lung associated. And then these are recognizable by both their imaging, their pathology, and the way that they behave. And so when we think of grouping PAH genetic disease, they're individual diseases, and we have to understand how these manifest and how to treat them uniquely. We know that the genetic background of children with pulmonary hypertension can influence outcomes. This is data from Ralph Berger in the Netherlands, and there's more to come with the newer defined syndromes. And we also know that with deep phenotyping, these abnormalities can have consequences beyond the pulmonary vasculature and really need to be thought of as a system-wide disease. And we see that in particularly with TBX4, which has not only vascular but lung manifestations, but also is a skeletal dysplasia. And we know that it's not only a disorder of lung branching morphogenesis, but also we can recognize this in the clinic. And so one of the first things we do now is to take off the shoes of every patient in the clinic, and you can actually make the genetic diagnosis right there, even weeks before our genetics return. Patients with syndromic pulmonary hypertension have significant representation in registries, and this is a really important area for gene discovery. So recently we started to define this. We looked at all of our patients with Noonan syndrome who had undergone cardiac catheterization at Boston Children's Hospital. And what we found was that this was a group of patients that had very complex hemodynamics and that had multiple manifestations. And of 87 patients, 13% of those had pulmonary hypertension, but with significant phenotypic variation. Of course, Noonan syndrome has been found to be associated with activating variants in genes of the RAS pathway, and we found significant differences in causative gene variants in our patients with and without pulmonary hypertension. So it's really important, especially as people are developing targeted therapies for the RASopathies, to capture additional data and to understand how this disease presents in our patients. And I think this is an area this is really unfolding rapidly. And in some of our cardiology rounds yesterday here, we heard about some patients with Noonan syndrome, and I think it's a very exciting and interesting opportunity. In pediatrics, it's important also to consider nutritional deficiencies. We know that restricted dietary intake can occur in children that have behavioral issues. And so particularly if you see a child who presents with hip pain and hypoxia, and they have tachycardia and perhaps corkscrew hairs and pulmonary hypertension, they can be treated very effectively and very quickly with IV vitamin C. And it's really important to include evaluation for nutritional deficiencies, including vitamin D, thiamine, iron, in the evaluation of our patients. And this just shows a patient that was really very sick and then very quickly had pulmonary hypertension resolved because of the recognition of scurvy and vitamin C deficiency. So how do we treat pulmonary hypertension? Well, pulmonary arterial hypertension therapies really work through four major pathways. First, the nitric oxide pathway with PDE5 inhibitors. The endothelin pathway. Endothelin is a very major cause of circulating endothelin. The prostacyclin pathway. And then the newer pathway, activin pathway, which sotatercept is an activin scavenger. And this drug rebalances growth promoting and growth inhibiting signaling, and is really the fourth pathway. And this is a drug that we are very excited about and really learning how to use. And these things are really our classical treatment. There are many new treatments that are on their way and that are being developed. And I think this is an area which is exploding for us in pulmonary vascular disease. So most pulmonary hypertension medication are not approved by the FDA in children. So here you can see a list of our current medications. The PDE5 inhibitors, sildenafil and tadalafil, only sildenafil is approved. And then of the endothelin receptor antagonists, only bosentan is approved greater than 3 years of age. And of course, the drugs that we use for prostacyclin treatment have not been approved, nor has sotatercept. So how do we decide how to treat these drugs and treat our patients? So pulmonary hypertension treatment is really based on risk. And we stratify by clinical features and echocardiography. Patients may be at lower risk or at higher risk. And some of the things are age. You're at lower risk if you are older, clinical evidence of RV failure, progression of symptoms, at a lower weight. Also, we use hemodynamics and we use cardiac MRI to do some of this risk stratification. And our initial treatment is stratified by response to acute vasodilator testing in the cardiac catheterization laboratory, where we use inhaled nitric oxide to determine whether patients respond to calcium channel blockers. And if our patients respond, and in pediatric patients, it's about 45% of the patients who do respond, a much lower percentage as patients get older, we would treat with calcium channel blockers. But the remainder of our pulmonary hypertension treatment is really stratified by risk. And so this shows patients that are at lower risk or at higher risk. And lower risk really has upfront or rapid combination therapy, whereas higher risk may start out with significant combinations of initial parenteral prostanoid plus oral therapies. Of course, if patients do not respond and they need serial reassessment, we use therapies for advanced disease, and that includes atrial septostomy, a reverse pot shunt, or pediatric lung transplant. So there are frontiers which affect our pediatric patient experience. And I think these are really important for all pediatric specialists to think about with regard to our patients. There are emerging areas in survivorship. There's impact of this disease on our patients and families. And there's important information about social determinants of health and how our patients do, and whether we need to use that and incorporate that into our thinking about patient outcomes. So with the first frontier, survivorship, with normal development, some children will grow beyond pulmonary hypertension issues. And of course, it's very exciting to see that our patients are living longer, doing better due to better care and treatment. They still face unknown cardiopulmonary risks in the future. And children who have pulmonary hypertension and grow into adulthood are clinically distinct from adults who present with pulmonary hypertension in adulthood. There's really a spectrum of pulmonary hypertension that's associated with development of lung disease throughout the lifetime of a patient. In infancy, you see a lot of the particular diseases of the lungs and disorders of transition. In pediatrics, some of those may become manifest, but you may see more presentation of some of the genetic disorders. And then in adulthood, there can be lung disorders and other disorders which actually were not even diagnosed in pediatrics, but can present later on. So one particularly interesting area to speak about survival is congenital diaphragmatic hernia. And more patients are surviving from infancy. On the right is really a three-dimensional CT, and you can see that the pulmonary vasculature in the contralateral lung is actually relatively normal, but the ipsilateral lung, the pulmonary vasculature does not grow, and the lung expands with significant emphysematous changes. So we know that when we look at pulmonary function over long-term in CDH, this declines with age. We also know that there's worsening VQ mismatch with age in our patients with congenital diaphragmatic hernia. So we have looked at exercise-associated pulmonary hypertension in long-term survivors. And so in our follow-up program, we do a routine exercise stress echo beginning at age 6 to 8 and repeat at every 2 to 3 years. When we first reported on our cohort, we looked at 84 patients with close to 175 stress echoes. 80% of them were left-sided. Half of them had larger defects, C or D. And at baseline, most of them were in relatively good functional class. A few had functional class 3 to 4. But what we found in this group of 80 patients was that 13 of the patients had right ventricular pressure greater than 60 on stress echocardiography. And of those patients, 10% did not have it at baseline. So our exercise-associated pulmonary hypertension wasn't associated with exercise parameters. It was associated with a larger defect and with patch repair. And when we took a proportion of these patients to cath, all of them had confirmed pulmonary hypertension without pulmonary hypertension on baseline echo. And so we had clinical managements that actually changed and treatment strategies that improved the pulmonary hypertension in this group of patients. So we know that CDH survivors have diminished pulmonary function over time and that they are at jeopardy for persistent vascular disease. And that report, which was done several years ago, has only continued to grow. And so we routinely do this testing, routinely cath our CDH survivors. And things like exercise testing can help us to identify subclinical symptoms and help us to facilitate early management in these patients. But there's a growing need for all of our patients with developmental lung disease to really optimize the way that we survey and study these patients over time. And that is only going to increase. That wave of patients with bronchopulmonary dysplasia, trisomy 21, and CDH are growing, and we really need to figure out the best way to care for them and to see them in clinic. We also need pulmonary rehabilitation and other cardiopulmonary services. So another issue in survivorship is anxiety and depression. And so we see this in our patients with pulmonary hypertension. This is a study that we did with the PPH-NET APP group with many of our centers that we did mental health screening in our adolescents. And we used validated screening instruments. Of our group of patients, half of them met criteria for moderate or worse anxiety or depression. And a third of them received counseling for that. Some were referred to our psychologists. The anxiety and depression was without association to age, their functional status, how severe their disease was, how far they were from the hospital, household income. And what we took away from this study was really that mental health needs are important in pediatric pulmonary hypertension, and there's no clear association, so that we really need to screen all of our patients. And in our clinics, we need to have adequate resources for counseling and mental health services. Really important as we turn pulmonary hypertension into a disease which is a chronic disease, but a disease which still is fraught with many hazards. And so what's the impact of pulmonary hypertension on children and our families? Well, pediatric pulmonary hypertension is a family disease. Genetic testing has implications for the family. Quality of life and the mental health issues really impact patients and families, and patients need to be prepared. They have very complex therapies, and they need to be prepared for whatever comes their way. So we know that many of our patients have pedigrees that really show a variable expression. And so the genetic findings in a child may lead to the diagnosis of pulmonary hypertension and other diseases in family members. This was a group of family members that had pulmonary hypertension in HHT. Some of the patients have HHT, but others have pulmonary hypertension and HHT. And there has been a very nice demonstration of genetic testing approach for pulmonary hypertension patients and relatives. We know that our probands that have group 1 type disease with idiopathic heritable disease, congenital heart disease, developmental disorders should be offered testing. But then what do we do with other family members? And how do we do testing? Well, we start with panels. We look at whole exome sequencing, offer whole genome, and our patients receive genetic counseling pre and post genetic testing. If we find a pathologic report, well, we evaluate those patients, and then we schedule regular follow-up with routine echocardiography, exercise testing, and surveillance for these patients, and they will need surveillance throughout their lives. So we know that there's a need for access, insurance, approvals, multidisciplinary teams, and this requires extensive collaboration between our team and even adult centers. This has a tremendous impact on our families. So quality of life in pulmonary hypertension is really incredibly important. And we know that for a variety of things that we've talked about, chronic disease, physical adaptation, need for complex management, and increased attention to immediate and long-term outcomes really lead themselves to say, well, we should study quality of life. So a number of years ago, we initiated a study, and this has been duplicated in many other centers and actually internationally, to study quality of life in pediatric pulmonary hypertension. And importantly, we found that quality of life was worse than healthy children, but also worse than children that had other serious diseases of childhood, and that 1/4 of the parents met criteria for presumed psychiatric diagnosis, and that the parental adjustment really informed how well the children were doing. So parental adjustment is a very important predictor of quality of life in our pediatric patients. This was our quality of life compared to healthy norms. And really, it was decreased more than any of our other serious childhood illnesses. We know that quality of life also can be used as an important endpoint in clinical trials. This is the Tomorrow study, which looked at macitentan and had quality of life as one of its endpoints. Now, macitentan did not achieve statistically significant improvement compared with standard of care, but the quality of life in the patients that were treated with macitentan actually went up and was statistically significant. So this may be an additional endpoint that we really need to look at. So I think that it's an important thing as we care for these patients, as they live longer, that we look at these treatment interventions for pulmonary hypertension. So what about families and the environment? Well, we know our children, particularly with cardiovascular disease and with pulmonary hypertension, are particularly vulnerable to environmental changes. And they may be particularly susceptible to climate stressors, environmental challenges, heat stress, pollution, allergens, and then also to acute weather and to climate disruptions, because our patients depend on a supply chain, and they may need oxygen and complex drug delivery. And in the US, global warming and other things may increase the risk of severe weather. And our children are also particularly vulnerable to power disruptions. So we sought to understand how prepared our pulmonary hypertension families were. And these are not just hypothetical situations, but they're real world needs. We had some patients who were in Los Angeles due to the wildfires where patients were evacuated. And then in Massachusetts, just this past winter, there was a blizzard and our patients could not get their medications. So they were traveling to emergency rooms really to get their supplies of their medications because they couldn't come up the Eastern Seaboard. So we have a study called the PEACE study, Preparedness and Emergency Action for Children with Pulmonary Hypertension, that we just reported at PAS, that had a survey for our patients where they were asked about their understanding and preparedness. And what we saw, it was favorable that a number of our patients were enrolled in emergency notification programs, but there were concerning things that many of our patients lacked documentation of their illness. They did not have a 3-day emergency supply, and half of them used medications that required a power supply, and they did not have a generator. So this is a real vulnerable area, but easily fixable with education and help for our patients and families. So then the last frontier they wanted to talk about is social determinants of health and outcome disparities in pediatric pulmonary hypertension. And this is something that happens internationally between countries, within our country, and within a center. So the Pulmonary Hypertension Global Patient Survey really showed significant disparities in access and coverage throughout the world. This particularly was true in things like genetic testing, where high-income countries could offer this, but not low-income and middle-income countries. And then in the prostacyclins, in parenteral prostacyclin and inhaled prostacyclin, where this was essentially not available in our lower or middle income countries. As well, the global availability of pediatric cardiac surgery, unrepaired congenital heart disease, a major cause of pediatric pulmonary hypertension, but in many parts of the world, we do not have sufficient manpower of cardiac surgeons to repair these congenital heart disease in time to prevent going on to pulmonary hypertension. And similarly, there's a social deprivation index, which really has served as a power predictor of pulmonary hypertension mortality in a number of surveys. And even though our outcomes have improved over the years, they have not improved in the same way across all countries. So we know that social determinants of health really directly impact pediatric heart access and outcomes. And so in our group, we sought to study this both nationally and locally. And this is work that was done by a medical student that I worked with, Jay Karana, as well as Katie Moynihan, who is a member of our cardiac ICU staff. And we really wanted to explain how our patients were doing with regard to social determinants of health. So we used the Child Opportunity Index derived from the US Census Tract, and we looked at a number of variables. And our paper in JACC Advances was just published, and this was looking at data from the Pediatric Health Information System, where we looked at a national level to study socioeconomic determinants of health in pulmonary hypertension across 47 U.S. children's hospitals. And across the U.S., lower Child Opportunity Index is associated with increased mortality. We also looked at our own institution and looked at this across the patients that we care for. And we used all patients at Boston Children's who had at least one ICD-10 code. There are ways of using the ICD-10 codes and associating that with some of the groups of pulmonary hypertension. And we looked at inpatient admissions really to match the FIS data that was looking at inpatient admissions. And as a result, we had 1,700 patients over our time course at Boston Children's with pulmonary hypertension. They reflected all of our groups. And what we saw was that Boston Children's has a distribution that had higher Child Opportunity Index distribution. But within that, our patients with public insurance had greater mortality. That wasn't associated with language or distance from the hospital. There was a relationship between race and mortality, and the quintile for Child Opportunity Index was strongly associated with overall mortality in our patients with pediatric pulmonary hypertension. And in multivariate analysis, greater odds of mortality were independently associated with lower Child Opportunity Index, particularly with education and housing, with Black and African American race, and insurance and language differences were not significant. So this told us that factors outside of our clinical hospital-based care are critical for pediatric pulmonary hypertension outcomes and really need to be factored into the way we study pediatric pulmonary hypertension and need to be included in our registries. And we need to develop interventions to address these disparities among our patients, perhaps including earlier diagnosis and better coordinated treatment, nurse navigators, particularly to coordinate that transition between the NICU and the pulmonary hypertension service, and to provide home-based services at appropriate levels. So in summary, there are tremendous opportunities in pediatric pulmonary hypertension. It's an explosion of disease opportunity with molecular definitions. We have robust, validated tools to measure physiology in our patients, and patient-centered outcomes are essential. There's the potential to mount prospective or randomized control studies in small cohorts of rare disorders. And we have to think about how we utilize our targeted therapies. There are many centers of excellence with well-established teams, and there is a lot of collaboration and a lot of opportunity for collaboration. And the community of clinicians and investigators that have cared for patients with pulmonary hypertension in childhood has really developed tremendously, and broad collaboration is very possible and very achievable. So I want to acknowledge the work of my team, my nurse practitioner team, Paul Kreitzer, who worked with me as a fellow on the exercise stress echo data, the group that looked at mental health studies, our BCH environmental health team, who's coordinating the PEACE study with us, Jay and Katie Moynihan, who looked at socioeconomic determinants of health, and as well all of the pediatric pulmonary hypertension community and colleagues, both nationally, PPHNet, and internationally, PVRI, ISHLT, and TBX for Life. Thank you.